Hey, what's up? Those of you planning to do your clinical rotation in preoperative services or plan to work in a perioperative service department and you just want to know more about the job and what it entails or just how to structure your workflow. In this video, I'll be going over preoperative workflow for surgical cases. But before we get started, if you're new to my channel, welcome. My name is Tina, nurse practitioner. Don't forget to subscribe and turn on that notification bell. Let's get started. So when your patient arrives to the hospital, they're going to check in. At that time, the patient will be provided with a number. So any family that are waiting in the waiting room, they will be updated and they'll be able to track the patient where they are in preoperative from surgery to recovery. So it'll be helpful for the family that are waiting. So let's talk more about the preoperative workflow. So the patient will be scheduled for surgery. They'll be provided with a time and date when to check into the hospital. But prior to surgery, the patient is required to be NPO, so nothing by mouth. The patient will be asked plenty of times when was their last intake of liquids or solids several times throughout their stay while they're getting worked up for surgery. In addition, the patient may have already gotten some blood work done outside of the hospital prior to coming in. They will be required to get a COVID test upon arrival or based on your hospital protocol. So make sure that there is documentation. There have been cancellations of COVID tests that are delayed or not resulted. So prior to surgery, the nurse will actually call the patient and prep them and ask that they come 2 to 3 hours prior to the start of surgery. This will allow the nurse and the medical staff to be able to do everything they need to do to get the patient ready for surgery, which is like consents and all the workflow. So once the patient is checked in, the care partner will verify the name and date of birth. The care partner will bring the patient in, get a set of vital signs, check their weight, and they will also provide them with a gown and instructions where to place their belongings. So any jewelry such as dentures, removables, partials, hearing aids, glasses that can be removed are asked to be taken off, including undergarments. If they brought medication of their own, if a family came with them, they ask that they are sent back with the family or send them to pharmacy. Some surgeries will require a skin prep such as chlorhexidine or nasal prep. Those that do not require chlorhexidine prep is any surgery where there is an incision. And you also have your MRSA swabs, which are typically for your orthopedic cases, such as like the spine. So now the patient is in the room waiting for the nurse. So prior to going in, with my flow, I always want to be organized. So I'll take a look at the chart. It should take me about 3 minutes. So I want to look to see if I have a resulted COVID test. I want to make sure there's consent for the procedure. I'm going to look at the time and date and make sure that the actual surgery is accurate and it's on there and listed. Some surgeons are really good about doing this prior to the surgery date. So they'll actually meet with the patient in the office to answer any questions and go over risk and benefits to prevent delays. And then if there is a location site that needs to be marked, I'll grab a marker such as like a right hip replacement. So I'll make sure it's at the bedside for the surgeon. So when he comes in and says hi, he can mark it and we're good with that. I also want to know if anesthesia form has been signed. Typically, it really is not signed prior. It is done the day of the surgery. So I'll keep a checklist of what needs to be done before I sign off on the chart. You will also need a blood consent for possible blood transfusion, so make sure it's current for the new admission, very important. I'm also going to need an updated HMP within the last 30 days. So a thorough one will include the subjective, the review of systems, allergies, medication, medical and surgical history, and then their assessment, diagnosis, and plan. You will also need a HMP attestation signed the day of the procedure. I will also look at orders such as like medications I need to give prior or labs. If my patient was female between 10 and 53 years of age, I want to make sure that I do a pregnancy test unless there's documentation of a hysterectomy. All of what I just did should take me no longer than 3 minutes. Okay, so now I'm ready to go into the room. I'm calm and collected. No one wants an anxious nurse because your patient typically is not calm and collected. So walk in confidently and assured. This helps ease the patient and family because you're their advocate. You're gonna let them know what they need to know prior to going into surgery. So first things first, I always introduce myself. Hey, my name is Tina. I'm gonna be your nurse today. I'll be helping you get ready before going into surgery. Then I will verify their name and date of birth. I'm gonna place 2 medical bands. 1 medical band on their arm and 1 on the opposite foot. If the family is at the bedside, I encourage them to take the patient's belongings so they don't get lost. If they do, I'll document in the chart all belongings with family, just in case it doesn't come back to us. At this time, I'll also verify phone numbers of the family members. I will update and make sure it's updated in the chart, and it's also on the paper chart as well. I'll also re-ask if there's any dentures, removables, glasses, or jewelry that need to be removed to remove them at that time. So depending on your workflow and availability of extra nurses, sometimes you will have an IV starter nurse. So as you're asking the preoperative questions, the nurse may be in the room starting the patient's IV. So it's very helpful when you're able to do a combo approach. So just so you know, the preferred IV gauge is 20 gauge. And if the surgery is on the left side, make sure you try and start the IV on the opposite side, so this would be the right side. If this is a pediatric patient, child life support will be present, and depending on the child, it's very likely the IV will be started in the OR with anesthesia, which is a relief for everyone. No one wants a crying child. If the IV is started at the bedside for the pediatric patient, sometimes they'll apply a Sonera patch to the patient's site prior to starting an IV. If blood needs to be drawn, this is the time the nurse will draw your type and screen, your check type. If you need AccuChecks for your diabetic patient, or if you need a potassium check, or for your parathyroidectomy patients, you may need a PTH order. So make sure that you draw it all at once when the IV is started. Now this is the time you wanna log into your computer and start charting. I'll have my screen open. I'll start asking all the questions. When you do this so much, it becomes redundant that you're just talking and asking the questions, and you talk a lot faster than you chart, so you'll go through it a lot quicker. So I'll assign my name to the case. I'll verify the times that the patient is in the preoperative phase. I'll ask when was their last intake of solid foods and liquids. I'll ask about their last time they voided. I'll verify if the patient has had surgery in the past and were they a difficult intubation, which is helpful for anesthesia, or if they suffered from post-operative nausea and vomiting. I'll also ask if they did any chlorhexidine wipes prior to surgery, or if they've ever been told they have malignant hyperthermia. So I'll go over the medications, the last time and dose. Any medications were taken prior to coming in. Sometimes I may need to do a reconciliation, so it's very helpful for the next medical provider, helps clean up the list and prevents any type of confusion and possible interactions with medications. Medications that are typically held are your blood thinners. The most common ones are like Plavix, Xarelto, Coumadin, heparin, aspirin, Celebrex. Some anti-diabetic medications may be held, such as metformin. So I'll continue to ask a lot more questions, such as pre-screening exposure, if they had any unexplained weight loss or trouble eating, difficulty hearing, or if they have traveled outside of the country within the last 30 days. This also captures your common COVID questions. Any loose stools in the past week. I'll also check my fall risk score for the patient and make sure it's charted. So after I'm done, I'll go ahead and I'll do my head to toe assessment, capturing respiratory, your neurological, skin, which is your integumentary. It should take me no longer than 2 to 3 minutes. However, if it's a neuro patient, my neuro screen is going to be a lot more detailed. Now I know we mentioned some details about the pediatric population, but I want to highlight a few pearls for you to take with you that's very important regarding pediatrics. So you always want to make sure you have your emergency pediatric drug sheet at the foot of the bed and one drug sheet inside the paper chart. This is weight-based and must be verified by 2 RNs and signed. If the child is greater than 55 kilos, no code sheet. That's right, I said it, no code sheet, unless they have some type of lymphatic disease, so a dry weight will be needed regardless. For your vital signs, if they are less than 10 years of age, be sure to get a pulse ox and heart rate. If blood pressure is needed, if it's less than 2, you're going to obtain it from the leg, and if it's greater than 2 years of age, you're going to obtain it from the arm. So moving on to the next pearl, for your pediatric surgical cases, if Versed is prescribed to a child, always remember, you got one shot, so make it count. You will ask the child if it's age appropriate, if they want it in a cup or syringe, because it's very likely once they take a sip of it, they're not going to want to drink it anymore. Moving on to the next tip. Some kids may just come in for an MRI. At this time, they will only need an HMP and anesthesia consent, no attestation, but it's also based on your protocol. So when a patient checks into the hospital and they are getting ready for surgery, not all of them are going to the OR. Some are going to the cath lab or the medical procedure unit or MRI or interventional radiology. So I want to highlight some important tasks to take care of prior to them going in. So for your patient that's going to be going into the cath lab for possible stent placement, you always want to mark the pedal pulses, including dorsalis and tibial pulses, and make sure that they are palpable, or if you need a Doppler to palpate them, note it and chart it. The next tip is some MDs may require or order pre-op meds to be given, such as a preloading dose of like Brilinta or Plavix or aspirin. So check your orders. If they're missing for cath lab, page the doc, so that way it's clear and you've documented that. Moving on to medications. So let's go over some pearls that are important reminders. So for your patient's status post-transplant on an anti-rejection medication such as tacrolimus, make sure they do not miss their dose prior to surgery, like no exceptions, never ever. Some patients will be ordered antibiotics for surgery, so your pharmacy will prepare it, so make sure you grab it and you hang it on the patient's IV pole. Do not start it. Anesthesia will be the one to start it. Unless you're told to start it, then please do so. The next tip is fluid of choice. The most common ones are your Plasmolite or your LR, which is your lactated ringers. So have it primed in anesthesia tubing and connected to the IV site, and that it's not infusing. Again, anesthesia will be the one to start it. Okay, let's talk about vitals. So your patient may receive a block. Not all patients receive blocks, but some do to help manage the pain. They will require continuous monitoring to include the blood pressure, the pulse ox, and heart rate. So once the block has been placed by anesthesia, you will have to monitor your vitals more frequently, like every 5 minutes for the first 30 minutes and every 15 minutes until taken to the OR. After you've done your part, you want to make sure you verify on your end that the patient is cleared and ready to go. This will prompt staff and the OR to speed things along if they are delayed. Hope you found great value in this content. Don't forget to give this video a big thumbs up, and I'll see you on the next one. Take care.